A shoulder injury can affect much more than the shoulder. For someone who farms, works in the forest, carries loads, or depends on physical labor, losing the use of an arm can affect work, income, and everyday life. But when a specialist meets such a patient, there is much more to understand than the injury itself. What happens when specialist medical knowledge meets the way people actually live? Today we speak to Dr. Chintan Desai, well-known shoulder repair surgeon from Mumbai, who has come for a camp in Gadchiroli research about injury, treatment, recovery, and what doctors can learn from the people they treat. Dr. Chintan Desai, we welcome you to our Search official YouTube channel. This is your second medical camp here.
Yes.
And if you can tell us how it all began and your first experience at Search.
Right. So for me, the first of all, when I started doing only shoulder work, when I trained extensively in that field, I knew that there was a need for shoulder problems, and shoulder injuries were fairly neglected, and not the outcomes weren't as good with traditional forms of therapy or treatment. And only a certain amount of patients did need a certain specific way of solving the problem for them to get back to work predictably. So that was my motivation to start doing shoulders only. Beyond which, my motivation to come to Search was a calling in a way to sort of meet the demands or needs of people who are unreached or have not don't have the means to access modern day medical facilities. And honestly, this is the place where there is the maximum need for such treatment. As you correctly put, that patients who are farmers, who are forest workers, need the use of their arm. Those are the ones they are going to actually need our services more than people who are mainly sedentary or office goers. So I also, in my part of practice, treat sports injuries and patients who dislocate their shoulders. So we have a huge number of people who are interested in sport or want to do sport, who have the potential or the physicality to do sport from rural areas, who don't have the means to get better after injuries if they sustained one. So our objective to come here is to try and cater to those people the best way we can, to sort of bring them back to work, and eventually, if they are sports people, bring them back to sport. I've learned from other people's experiences to be able to come to Search, where the facilities are good enough for us to support our kinds of medical interventions. It still requires, from our perspective and point of view, to our procedures are very equipment heavy. We need very modern day equipments to transport over here to be able to do that. And we have been trying our best to get the best we can to the place, to such a remote place in the interiors of Maharashtra. These facilities are fairly well established in urban areas, but the demands of the people in the rural areas are more, and hence I think there is a huge gap in services providers who are well trained enough to do this. The eventual objective is to pay it forward, in which, I don't want my expertise or techniques to die with me. I want people to know about them, and also trainees or surgeons to learn from this, and then for them to be able to provide the same quality of service only if there is training. So that training is another motivation or sort of intention to come here and train young trainees to do the similar kind of procedures that we are able to do in bigger hospitals in Mumbai.
What has been the disease burden that you see in rural setup like this compared to where you have been working?
So disease burden is fairly more, I would say, in the rural areas as compared to places like Mumbai. Mostly in urban populations, sports injuries or gym-related injuries of the shoulder are fairly more common. Degenerative injuries exist, which means elderly people with shoulder arthritis or shoulder problems is there. Degeneration or wear and tear is present. The pain is pain. So, I mean, patients who are painful are the ones that need us to solve that problem for them. the main disability in the shoulder comes from inability to use the arm or elevate the arm at all. So when the needs are high, so for example, a patient who or a person who is more sedentary at home, may it be rural or urban, may probably not need a significant surgical intervention if they don't need to use their arm as much. Vis-a-vis, if you see a rural population, there a loss of usability of the arm is loss of work, is loss of income, and that loss of income translates into several family socioeconomic issues. So in terms of disability, if we are able to bring those patients back in the rural area, back into their work, the sooner the better for them. So the requirement of the treatment is much more, I would say, in rural populations, because the use of their arm is, the necessity for them to use their arm is more.
And in last two camps, any patients whose story has stayed with you
Stay back.
for a long back, and something which is like you have always seen in theory, but something which has made, matlab, you have the whatever the learnings have been in the last two camps, if you can highlight, touch base on that.
Yes. So theoretically, if there is a damage or an injury in the shoulder, you need to fix it for the shoulder mechanically to function well. But sometimes biology and human endurance and resilience is something which we can't explain in some patients. So for example, the patients that I've treated yesterday for muscle injuries have been using their shoulder in spite of those muscle tendon injuries for more than 2 years. So it's just that they need to, but then they now are experiencing more and more pain and discomfort, and now they've reached a resilience point that they can't tolerate it. That's when surgical interventions are necessary. Vis-a-vis, if those were done much earlier, I think the amount of disability that they face now could have been reduced. However, the intervention is only catered to patients who want to get the intervention, in which if there is a tendon injury, let's say, if the patient has very good function, doesn't have as much pain, we are not very keen or upfront to tell them that you need to get operated, although we know that probably in another 2 years' time that may become symptomatic. And that information is important for the patient to understand and know. So in the rural population also, when we inform them that this is possibly going to get worse over a period of time, sometimes we don't see them getting that bad that soon, because the physicality of their muscle structure is a lot different than someone who's more sedentary. So the other muscles that work for the shoulder sort of take over, and they are able to resiliently carry on further. So that's the only there's a lot of research needed to be done as to, even if this is a situation where the patient, we are unable to fix their shoulder or repair it, how are they able to cope to bring their function to their optimal position or level. So that would be one of my objectives, to learn from the rural population as to, in spite of their shoulders not function or structurally being injured, are still able to do their activities to the best possible way they can. And hence, not every patient needs surgery. Every shoulder pain doesn't need surgery. Every shoulder pain can be solved very effectively with conservative managements, with particular exercise and physiotherapy. So the learnings from here can be taken back into urban populations also, where the situations or the bad situations from here, how the patients are able to cope with them. That coping mechanism is easier for our urban population then to understand. And then the effectiveness of that is obviously something which we need to study.
So anything that has changed the way you would treat patients, your course of treatment from here?
So from here, as I said, the basic structure or the framework or the flow chart that we follow as to the protocol, as to what needs to be done, the objective is not to change the standardized protocol dramatically, unless there is some research backing to it. For example, let's say a patient who has a very stiff shoulder. We know that stiff shoulder is going to improve eventually or let's say a frozen shoulder is going to improve eventually. Generally takes 2 years for them to improve. So the change in this pattern of treatment is where in the rural population, theoretically, if I release their shoulders earlier or open them up, they can go back into activities much sooner. Vis-a-vis, we that can probably be treated without the intervention as well. So more aggressive management, I guess, in that population or that difficulty is necessary in the rural population compared to the urban. So that's possibly one change that I would make for the rural population, probably intervene a little more earlier as compared to a patient in the urban population.
Okay. What do you see when specialist care meets a rural community?
There's a big difference. There's a life-changing event in most people's life, I guess. So they return back to activities much sooner, faster. They are able to become pain-free more predictably. I would say shoulders are shoulders. I mean, it's a shoulder being treated in Mumbai in the urban population is the same mechanically as a shoulder in the rural population. So if there is a damage, a disability associated with it, effective intervention solve them predictably, and patients can get back into their activities and work much easier, faster.
As a person, has rural medical camps helped you change as a person?
For sure. I mean, unless we see the discomfort or the disability that people face in their day-to-day basis, we don't understand the gravity of the situation. As to people who we meet over here have literally no means to even have a meal sometimes. And that affects us in a way that we have modernized so much in where we live and where we work, but people here still can't survive.
We were talking about this gap of healthcare for the orthopedic. How, according to you, that gap can be reduced?
It's only through interventions in the community and with community awareness, I feel. That honestly, even in shoulders, as you see, not a lot of surgeons take up shoulders as a specialization, but there is a huge need for it. The more people are aware of solutions to these problems, the faster they can understand the ways to and means to get better. It's a very large problem to solve in a simple conversation. I feel it needs a lot more work from the government or the administration side, where we need smaller pockets of smaller primary healthcare centers to pick up or screen these people to the people of need, in which if they have a particular problem that is recognized as diagnosed and then is brought to us. We need a lot of diagnostic tools before we intervene. So we just can't intervene on clinical judgment anymore. We can, but it's often can go wrong as to vis-a-vis improve patient health. And hence diagnostic modalities, availability of diagnostic modalities is something that needs some more work in rural communities or areas. It's not very hard to do, I think. We have a lot of CSR opportunities that can pick up things like this, where diagnostic modalities can be focused on and then interventions can be planned. So the primary thing is diagnosis.
So if you were to design a system of shoulder care for people living far from a specialist like you or specialist centers, what would you want to learn from the community before designing the system?
Yeah. So that's the research we want to perform over here in terms of the number of patients we see here who don't need significant intervention. Simple solutions or exercises that can help to improve their shoulder function is what is important for us to learn. Once we learn that, we can formulate a plan of minimal intervention with maximum effect. For example, a patient who has starting to develop stiffness and is diabetic, we know that that can be a frozen shoulder. So recognition of the problems. Secondly, early intervention to improve the sugars, and then persisting to do physiotherapy or exercise to prevent stiffness from developing. So, how long does that intervention need to happen? Is that intervention improving patient health? That is what we need to study then to implement this on a larger platform and to formulate some structure. So once we have that intervention in hand or understanding of that, we can then have a larger community basis of of healthcare providers to teach that intervention to people of need.
One last question to you. After working with patients in different settings, setups, urban and rural, and type 2, tier 3, what is one thing you think as a specialist need to understand better about the people they treat?
Uh, peop- uh, I would say only symptomatic patients are the ones from a surgeon's perspective that need intervention or surgery. Surgery is often looked upon as the last management option, but in certain cases it is not. In patients who have fractures or who have broken their arm in ways that are difficult to mend correctly, those are the ones that need earlier intervention than being conservative. So there is a bit of what do you say, objective lack of understanding or fear of a surgical intervention. So that is something which I would like patients to understand, that now surgery is fairly safe in terms of the anesthesia point of view. Obviously, pre-operative health checkup is more important to understand the risk factors and then intervene.
Okay.
So that is something that I would like to impress upon people, that it's not as that we can't change things.
A successful operation repairs an injury, but a good healthcare may need to ask a larger question. What does this person need to get back to life they want to live? And perhaps there is where medicine and people's lived experience meet. Thank you, Dr. Desai, for this insightful conversation with us.